brain maturation. If you have bleeding in older infants, you should also look for underlying pathologies other than that. As far as the bacterial infections are concerned, these will very often be E. coli or other gram-negative agents or Staphylococcus aureus. It's worth to notice that the microbial pattern in small infants is different than the microbial pattern for CNS infections in older children. And then, of course, we all know that some intrauterine viral infections can lead to congenital hydrocephalus. These can be difficult to distinguish from the other congenital malformations. Now, concerning the congenital malformations, the main types are shown here: hydrocephalus related to myelomingocele, congenital aqueductal stenosis, cystic malformations of the posterior fossa, and in other locations. Now, we all know that MMC is a leading cause of congenital hydrocephalus worldwide, but the geographically distributed incidence is very variable. In some countries, it's still one or the most common congenital malformation, and in other countries, MMC is a rare disorder because of folate prophylaxis and preterm pregnancy termination. Genetic disorders are, of course, the X-linked aqueductal stenosis, but that is very, very rare. I shall come back later to a multigenetic explanation, which is probably much more common. And just make a note that the genetic disorders may possibly be related to genes behind ciliary expression, both in ciliary function and ciliary formation, and that this could actually have a direct influence not only on CSF propulsion, but also on structural development on some parts of the CNS related to the CSF pathways. This is undergoing research, but I think we'll be seeing some of that in the near future. The risks for multiloculated hydrocephalus, which is a particularly difficult issue to be dealing with, is almost exclusively related to IVH and bacterial infections. I will only mention this very briefly, as I know there will be a talk, I think tomorrow, by Professor Tomare from Germany about complex hydrocephalus. So I'll just leave it there. Now, the main point about clinical presentation is really the first line on this slide, namely that regardless of the underlying etiology, the children will clinically look almost the same. We all know what infantile hydrocephalus looks like clinically, but I'll just briefly mention that I tend to think about the clinical presentation in two headings, namely one, the appearance of the head, and the second issue being the clinical, neurological, and behavioral symptoms. I think I need not go into that, but I think the drawing quite nicely shows at least the head, typical head appearance with the enlarging head and the signs of increased intracranial pressure. The next item I will touch upon is temporizing management of post-hemorrhagic hydrocephalus. The reason for including this among the selected topics is that this is still a difficult and controversial issue being debated and discussed still. We all know that the severity is divided into 3 grades according to the the pathology. The least severe grade being just germinal matrix bleeding, and with progressing severity of bleeding into the ventricular system, dilatation of the ventricular system, and venous infarction in the germinal matrix area. Now, everybody agrees about these 4 grades, and it's universally used. There is no controversy here, but I think, unfortunately, that agreement stops here. Well, we all agree also that the grades 3 and grades 4 are the the grades where you see the highest risk for hydrocephalus. The risk for hydrocephalus is not very high in the grade 1 and grade 2s. Now for the difficulties and controversies. Relatively recently, there was a series of reviews published about pediatric hydrocephalus and recommendations for that. And one of the parts of this series of publications dealt with management of post-hemorrhagic hydrocephalus in premature infants. This was a systematic review, which means that it looked at the published literature and the quality of evidence in the published literature, trying to make some evidence-based guidelines for those recommendations. And they found that there were 7 recommendations. I would rather call it 7 statements for management of this clinical entity. They found 3 recommendations or 3 statements of level 1 strength and 2 each of level 2 and level 3. Now, I think it's worth to mention that these levels are according to the type of published evidence, not necessarily relating to whether something is true or not, but just as to how these what was the design of these publications, whether they were randomized controlled trials or large clinical observational trials or smaller clinical series or case reports. So it doesn't mean that something is more true than other. It just means how strong is the evidence. And the evidence traditionally is divided into high, moderate, and low. And I will use these color codes going through the evidence in this systematic review to show what they actually concluded in the end. The recommendations deal with 3 issues, one of them being the surgical temporizing measures. And the first statement was that they found in the literature that ventricular access devices, Meyer reservoirs and similar, external ventricular drainage, ventricular subgaleal shunts, and lumbar punctures were the clinical options they found published in the literature. But they also stated that the clinical judgment for choice is required, and unfortunately the strength of recommendation is only level 1, moderate. We have these options and that's it. The second statement deals with the statement that VSG shunts could reduce the need for repeated punctures compared to ventricular access devices. They found only moderate level of certainty for that statement. And the third statement was about serial lumbar punctures, stating that the routine use of this option is not recommended, and it does not reduce the risk or the need for shunt placement later. And this not to do recommendation was level 1. The second topic they dealt with or found in the literature was the non-surgical temporizing agents. As you can see, both statements are in green, which means that they were high level of clinical evidence, stating that intraventricular thrombolytic agents are not recommended and they do not reduce the need for shunts, and stating that acetazolamide and diuretics are not recommended and they do not reduce the need for shunt placement. The third issue, which is probably most of most interest to us as neurosurgeon, is the timing for shunt placement and whether we could do endoscopic third ventriculostomies. And unfortunately, these are both in red, meaning that there's level 3 or very unclear evidence. There is no literature-based evidence recommending neither the body weight of the infant or any CSF parameter to direct the timing of placement. We all know that we use these parameters. It doesn't mean that it is untrue. It just means that the clinical evidence documented statistically is not there. As far as endoscopic third ventriculostomy, it's the same story. There's not sufficient evidence to support that this could be an option instead of some of the other measures. So we can see that as far as evidence-based recommendations go, the published literature is much better at telling us what not to do, what recommendations to follow in that direction. And there is much less or no consensus or documented statistical recommendations for actually what to do. So this is still a controversial issue. So what we're actually left with, according to these recommendations, are these different types of temporizing measures. We can do a ventricular access device as shown at the top left corner. We can do a ventricular subgaleal shunt as shown in the lower left-hand corner. We can do an external ventricular drainage as shown in the upper right-hand corner, or we could do endoscopy with lavage, which I think Dr. Tamale will also be addressing probably on his talk tomorrow. But these are the options that we generally have to deal with post-hemorrhagic hydrocephalus. Now, this is pretty messy, actually, and this is exactly the reason for the TROPHY study. The TROPHY registry study is a multi-center international prospective data trial. It includes neonates who are less than 41 weeks of gestation at the first intervention, infants who have IVH with a need for surgical management, and the inclusion is using one of the shown temporizing surgical interventions, each used as the standard treatment at participating centers. I think actually this is a particular strength of this study because each center will use the method that they are used to, so you'll get the optimal perspective for each method rather than centers randomizing and including patients doing interventions that they're less used to doing. The results eventually will probably show us whether any of the methods in the best of hands is optimal compared to others, whether complications and mortality will differ, and whether it has any influence on subsequent surgeries, particularly, of course, shunting and the neurological outcome. I believe that this study is still open for participation. I can only encourage people, if that is so, to participate because we all need this evidence. The third topic of my talk is about permanent management, and of course, in very short term, that will deal with shunting versus ETV. And as I said before, the reason why permanent is in inverted commas is that we have problems with durability of the treatment that we offer for the pediatric hydrocephalus. Shunt statistics are pretty well known. The curves look like this. This in particular shows that the risk for shunt malfunction and the risk for further surgeries increases with the number of surgeries. Regardless of which type of shunt you use, there will be small differences in the shunt survival curves, but still the same pattern is seen. And this is another way, a third series. You can get Many types of curves published, and they all look like this. So we do have a problem with shunt durability, and they sum up to the statement below, namely that there is a strong statistical evidence that less than 30% of shunts in children will last beyond a short period of time, a few years. And this means that the average child will have several shunt surgeries in their lifetime. And this is something you need to face up to when you place the first shunt. You have to face this reality. This is, of course, the reason why endoscopic third ventriculostomy has been such a hot topic in trying to avoid these shunt complications. Some of the best papers on some of the most well-known papers on this issue have been performed actually in African populations with an impressive number of included patients. One of the first papers looked at endoscopic third ventriculostomy with or without cauterization of the choroid plexus, looking at the success rates for different types of hydrocephalus, and looking at the question whether additional plexus cauterization might increase the success rate. And the results of this briefly summarized below. With plexus cauterization, you get roughly a 60 to 75% success rate for hydrocephalus treatment, regardless of type, across myelomeningocele, non-infectious being mainly hemorrhagic, and post-infectious, but particularly for MMC-related and non-infectious. The CPC addition increased the success rate in this series rather dramatically. I need to note that some of these results have been difficult to repeat in other settings. Another paper from the similar setting in Africa dealt with the question of shunting versus ETV. They looked at the clinical outcome at a slightly longer term, and they found that there was no difference between motor and language performance, rate of treatment failure, complication risks, and brain volume, which is sort of a parameter for neurodevelopmental performance. So we dealt with these large African studies, but the question is how we can maybe also utilize this this experience in other socioeconomic settings that remains to be answered. Based on these large African studies, a protocol was proposed, which puts a particular emphasis on primary use of ETV rather than shunt. The reason, of course, being that the access to follow-up control and shunt revisions is much more difficult usually in these settings. And what they found using this protocol, which emphasizes or prioritizes ETV whenever possible, was that half of the kids could do without a shunt, also in the long-term run. And they proposed that this could be a strategy in low-resource countries for the reasons mentioned. But I think also we need to reflect whether this experience could actually also be applicable in other or high-resource settings, because here we're also dealing with a number of shunting issues, and it would be a gift to avoid some of these do and redo and redo and redo shunt kids. The protocol as encircled, as is shown encircling, this is one of their decision diagrams, and some of the major points is actually looking at scarring of the basal cisterns, and that is a major determinator for performance of ETVs or not. And that might actually be one of the experiences that we could, so to speak, export to other settings than so-called low resource settings. This is a high resource setting, the IIHS, which was recently completed. This deals also with ETV in very young children under 2 years of age, but the population selection was congenital aqueductal stenosis and none of the other pathologies. So we need to realize that this is a very select series. It was a prospective, non-randomized trial done on a multi-center basis. I believe that the ambition originally was to do it randomized, but it turned out for parental preferences that this was not possible. So they went on to do the trial as a non-randomized observational. And the main results are here. They can be divided into a shorter term or revision rate outcomes and into long-term functional outcomes. And as far as the revision rate, or shall we say surgical prognosis, it turned out that the time to primary revision or first-time failure was shorter for the ETVs, which is shown here. In the long run, only 20% of the shunts failed. So if you are addressing or if you prioritize the need for not failing early, then a shunt is probably an option. But if you prioritize the possibility to do without a shunt in the longer run, and you're willing to run the risk of an earlier failure, then you can choose an ETV. The reason also being for that statement that in the long run, there was no difference between shunt placement difficulties or shunt patency, whether the second shunt followed a previous shunt or whether it followed an ETV. Also, the long-term functional outcome at 5 years of age, the functional index in this very select cohort was identical. They were generally doing quite well. I think we all know the Kulkarni success score shown at the right-hand side of this slide. It is a very useful and robust way of estimating the success, the statistical success for ETVs. The score obtained translates directly into the percentage rate of success. I don't think I need to deal with going through this table as it's pretty self-explanatory, and I suppose that most of us know it already. But what I would like to go to is to address this score in relation to the literature that we've just been going through, relating it to the interpretation of the later literature, helping you to think about considering a primary ETV versus a primary shunt in these very young kids. So if you prioritize sooner versus later failure and non-function, then it's probably better with a shunt. If you are not so worried about that and would like to have the possibility of remaining shunt-free, then ETV could be an option. And if you are thinking of a primary shunt, the complications in full-term babies who are normal body weight for age, the risk of shunting is relatively low, particularly since the BASICS trial with the antibiotic impregnated shunting. Of course, putting a primary shunt in premature or low body weight infants is a much more complicated issue because of skin healing problems. The other thing about shunts is there is a propensity, at least in some settings, to go on with a shunt once you ended up with a shunt in the first place. But I think this is a question you need to address every time a child comes with a shunt dysfunction, whether it is a possibility to change the shunt from a shunt to an ETV. So once a shunt is not always a shunt in my mind. Particularly if shunt fails in older children, you might look at the possibility to try to make a transition to an ETV, particularly as the weight of the Cochrane success score is very, very heavily on the age of the child. The next part of my talk deals with age-related ICP values and some personal views on valve choices related to ICP values. These are some of the data you can find in the literature. The common perception is that ICP is low in infants, so we tend to choose a low pressure valve. But the question is whether ICP is actually low in children and whether it's actually lower in children than in adults. And there's very little evidence to support that. These are two of the publications looking at age-related ICP measurements. The one at the left side is from Queen's Square in London, and the one at the right-hand panel is from my own group. As you can see, both very clearly show a decreasing trend of ICP versus age. The London data do not really include children except older teenagers, but the data from my group does include some children with the same pattern. So I think it's relevant to ask the question whether it's actually true that ICP is low in infants. And we have chosen, based on this, to change our strategy for initial management of infantile hydrocephalus. We all know that water will follow the route of lowest resistance, and that also goes for CSF. So if the resistance along the shunt through the tissue in the channel you created, pulling the shunt through, if the resistance along that channel is less than the resistance through the valve, then of course water will collect around the shunt and rather than run through the shunt. And this is, in my mind, one of the major considerations that have led us to choose shunts with a very low opening pressure, is to avoid this bulge. So some valve considerations in infants, in my mind, is that we're dealing with a situation with open sutures and a soft cranium in the beginning. But we face major biomechanical changes to occur within a relatively short time span. We face transition to a hard cranium where the fontanelle closes and the sutures close and the bones become more firm. And also what we face is an increasing time in upright position. Babies mainly lie down, and the older the child gets, the more time it spends upright. And the ICP is strongly dependent on vertical versus horizontal position. So the requirements for the from the valve changes a lot from the infantile to the slightly older child. So theoretically, the way to address these changing physiologies would, of course, be to be able to change the shunt, which, of course, means a partly or a fully adjustable system. But there are some drawbacks. Adjustable systems are mechanically much more complicated than fixed valves, and theoretically, that would lead to a higher risk of malfunction. They're much, much more expensive. And as infants have a higher revision rate, they may actually have a revision before this theoretical advantage pays off. So you waste an expensive adjustable shunt because the child has a shunt revision before you need to do the first shunt resetting. And again, if you have very small children with low body weight and premature, adjustable valves are generally too bulky, and fixed valves are much more slender, which means a lower risk of skin problems, healing problems, and skin erosions. So my personal view for valve choice in this particular age group is that if at all possible, I would prioritize the possibility for adjustment during and related to growth. I would use an adjustable differential pressure valve, if at all feasible, related to size and body weight. It is always necessary to include an over-drainage protection. There are several types of devices. We use an anti-gravity device of 20 to 25 centimeters of water, meaning that this is what is added on when you change the position from horizontal to vertical. We use the initial setting of the differential pressure valve to 2 to 3 centimeters of water for about a week, which is equivalent to a low pressure, of course, to avoid the bulge. Then when the skin and subcutaneous tissues are healed, then after about a week or slightly more, we can increase the opening pressure to 5, and then we can gradually increase over the next months to 8 to 10 centimeters of water, which will relate to the oh, I'm sorry about this, which will relate to the pressures that we have measured in the series I showed you. It is possible to use a capistrum. I couldn't find a picture with a baby capistrum, but we do use those in babies. But if you use a capistrum around the shunting subcutaneous channel, then you can avoid the collection and maybe use a slightly higher opening pressure. This could be an advantage in kids with very, very large ventricles where you do not want the ventricles to collapse. If we are dealing with very small premature infants, we tend to think below 2,500 grams. We would recommend a valve system as slender as possible, and in practical terms, this would mean a fixed pressure valve, but please with a built-in over-drainage protection. I have absolutely no evidence to support me for the 2,500 gram recommendation here. As I showed previously, there is no high evidence in the literature to support any rigid ranges for body weight in terms of choosing a particular system. Finally, a few words about counseling for parents, outcome considerations, and genetic counseling. Pardon? How am I doing for timing? How am I doing for time?
You're fine. You can wrap it.
I have 5 minutes. Okay, that's fine. Thank you. I can finish up in 5 minutes. Many patients, or almost all patients, would have a number of questions and a number of doubts when they have a child with who's born with hydrocephalus. One of the issues coming up rather quickly is the risk for other children that they are going to have, whether they will run the risk of having hydrocephalus. The question about the functional outcome in this child, how is the child going to do? And very often these parents are completely unprepared for the burden of living with a shunted child, with the need for follow-up and revisions, which is also something that you need to counsel them about gradually. This is a statistical study from a registered study from my own country, Denmark, which is a large-based population study over 30 years. So it includes about 70,000 patients. The population risk, as is shown here with the arrow, is about 0.1%. So 0.1% of the general population has a risk of hydrocephalus. If you're dealing with twins to a child of hydrocephalus, the risk is 40 times higher. But 40 times higher means that the risk is still only 4%. So in the closest genetically related persons, the risk is about 4%. In other types of genetic relationships, the risk or the recurrence rate is only about 1% or lower. The red line here is a 1% line. And for siblings, and all future children will be siblings, the risk is just under 1%. So in short words, this means that there is a genetic risk. It's 10 times higher than in the general population, but it is still only around 1%. And I think that's very comforting for most parents to children with hydrocephalus. The functional outcome, as we all know, is a spectrum. As surgeons, we tend to deal mainly with surgical mechanical shunt problems, but in fact, these families and these children face a cohort of other problems in a very differentiated patterns. They can have problems of cognition, social behavior, epilepsy, autistic disorders, a lot of different problems. And these, in the end, become much more overwhelming than the neurosurgical issues. It's very difficult from the start to say whether you end in the area where you have a lot of problems and stay with a lot of problems and a poor functional outcome, or whether you actually have an intermediate or a very good prognosis with a functional outcome. It's almost impossible in the infantile situation to see which of the spectrum you actually end up on. So I tend to be very careful about statements on this in the beginning. I think we can skip some of these for the sake of time. Just stating that the large majority of studies in the literature deal with shunt complication and statistics and shunt survival and maybe short-term outcome, but very few actually deal with the long-term outcome. If the child is, if the child in the infantile age has obvious neurological deficits, then you have a prognostic idea, but only a prognostic idea very early, but this child is probably going to do poorly on in the long run with development. But again, you cannot be sure. If the child is doing very well and seems to be following age-matched milestones during the first time, then you need to be aware that some problems, particularly in cognition and learning, can appear later. This is a Swedish study, population-based, looking at learning disabilities, and they found that roughly 1/3 had a normal IQ, roughly 1/3 had low average IQ, and roughly 1/3 were mentally retarded. Amongst the ones with a normal IQ, you did have a, shall we say, a differentiated pattern with a much better verbal performance compared to some other cognitive issues. And children with CPs and epilepsy generally had a lower IQ and a lower functional outcome. Very long-term follow-up is also interesting because we treat children not because they need to stay children, but because they eventually grow up and become adults. So actually, there are very few studies looking at the long-term issues of treating pediatric hydrocephalus. But this is another Swedish study looking at the children who had a normal IQ assessment when they were small children. And fortunately, I think this is really good news that they stay with normal IQ as adults. And the number and types of shunt complications do not seem to topple that over. But the, shall we say, the differentiated pattern of some weak cognitive areas with the processing speed and the difference between verbal performance and other cognitive skills stayed the same. So finalizing, this is what we've been looking at: etiologies and clinical presentations, words about temporizing management and the trophy trial, some issues about shunts versus ETVs, my own recommendations for shunting related to documents on age-related ICP values, and then finally a little about parental counseling. And that's it. Thank you very much.
Thank you very much, Marianne, for a most interesting lecture. So unfortunately, there is no time for live questions, so you can answer the questions in the chat. There are some questions already written there, and maybe someone else wants to write their question there. And I give over stage to Dennis to present the next speaker. Thank you.
Thank you, Nina. The next speaker is Professor Rajat Gupta. He is a professor of neurology at the Aston University in Birmingham and a consultant pediatric neurologist at Birmingham's Children's Hospital. And as such, he's the director of their pediatric neurorehabilitation program. He's very important as a co-host of this course, and he's the person who managed to get the CME credits approved. So it's a big honor to announce Professor Gupta. His talk is about pediatric neurorehabilitation.
Thank you very much for the nice introduction. First of all, I'd like to also thank Naren and all the organizers of this excellent meeting for inviting me to speak. It is truly an honor to be speaking among esteemed pediatric neurosurgeons. As you mentioned, I do lead the Pediatric Neurorehabilitation Service at Birmingham Children's Hospital and work very closely with the neurosurgical colleagues here. So these are my declarations. I have received a number of educational grants from pharmaceutical companies. So first and foremost, what is neurorehabilitation? Now, there are a number of definitions out there. The first one's from Wikipedia. It's the first one that comes up when you do a Google search. And it states that neurorehabilitation is a complex medical process which aims to aid recovery from a nervous system injury and to minimize and or compensate for any functional alterations resulting from it. However, this does actually miss an important aspect of neurorehabilitation, which is noted in the second definition. And that is, neurorehabilitation is a spiral management process in which a treatment program is initiated and then constantly revised and updated based on the therapy-mediated improvement. So neurorehabilitation is a constantly evolving process. It's ongoing. It's not just a one-off process. So which patients need neurorehabilitation? Now, we're all aware of traumatic brain injury patients and spinal cord injury patients, but there are a number of other patients who would not necessarily come to mind immediately that do need neurorehabilitation. So children, for instance, who have developed encephalitis, whether that might be autoimmune encephalitis or infectious, stroke patients, children with epileptic encephalopathies, even those children who have undergone epilepsy surgery and developed motor function problems subsequent to the surgery. Pediatric cancer patients, not because of the primary effect necessarily of the cancer, but also of the secondary effects from the treatments like radiotherapy and chemotherapy. Children with inherited metabolic disorders, so for instance, children with mucopolysaccharidosis, Molkio syndrome, who've undergone spinal surgery and unfortunately developed complications of it. So there are many other children that we end up seeing apart from those who've just got traumatic brain injuries and traumatic spinal cord injuries. The size of the problem. Acquired brain injury is a leading cause of death and disability, both nationally and globally. And in the UK, it's estimated that about 40,000 children will suffer a brain injury. And of those, 6% are severe, 8.5% moderate, and the remaining 85.5% mild. Now, the classification of traumatic brain injury does vary in the literature, but most classifications basically utilize the GCS as one of the most important factors. So a mild traumatic brain injury is classified as being GCS 13 to 15, moderate 9 to 12, and severe less than 9. Another important factor that most classifications use is the duration of loss of consciousness post-injury. In mild, less than 30 minutes. In moderate, between 30 minutes and less than 24 hours. And in severe, beyond 24 hours. This is a bar chart from a study in 2015 and published in 2016 by Lawrence. And they basically looked at the number of individuals, this is children and adults, presenting to the emergency department with traumatic brain injury. So in just over a year that they were actually looking at, there were just under 16,000 patients who presented. And you will note that there are two main spikes with regards to the age of incidence with regards to the traumatic brain injury. So in older children and young adults, and then obviously in the elderly population. And in the elderly population, the most common cause for traumatic brain injury, understandably, is falls. In the very young children, so under 10, the main cause for presentation is basically falls, but also child abuse injuries. And then in the older children and young adults, road traffic collisions, road traffic accidents are the most common cause, followed by falls and assaults. Now, the incidence of brain injury in children from other causes, these are relatively small, but are important. So non-traumatic coma associated with severe or moderate encephalopathy, such as from infections, is about 4,000 per year in the UK. Paediatric stroke, it's estimated at about 2 to 3 per 100,000 children per year who have a stroke, and that basically amounts to around 200 to 300 cases per year in England. And then the brain tumor survivors, there's approximately 525 new cases in England per year. So these are small numbers, but not insignificant. Now, as neurosurgeons, you're all very much aware of the importance of instigating the right treatment when children and young adults present with traumatic brain injuries. And that's primarily to reduce the impact of secondary brain injury. So what you're trying to obviously do is ensure that oxygenation and perfusion to the brain is maintained throughout. I'm not going to speak any more about this, and I'm sure that this will be discussed later on in the course. So neurorehabilitation, often we are called in somewhat as a bit of an afterthought. So basically, once the child has been discharged from intensive care unit to the ward, that's when we're often asked to be involved with these children and their families. But I put it to you that neurorehabilitation should actually be something that starts right at the beginning. And that is because there's an important maintenance phase to this child's recovery before you actually start seeing the improvements. And one of the roles of neurorehabilitation in the acute phase is actually preventing secondary problems from arising, and therefore monitoring for these problems and identifying them sooner and putting the managements in place sooner. And the problems that you may get are actually musculoskeletal problems. Spasticity may start developing relatively early, ensuring that skin health is maintained. The respiratory physiotherapy would be involved in ensuring that the respiratory function of the child is optimized. And therefore, things like simple handling managements of these children are extremely important. Positioning, turning, stretching muscles, so on and so forth. Another reason why we should be involved early on is because the neurorehabilitation team can actually be an important part of complex and difficult discussions regarding the child. Often we sometimes think because we can perform an intervention that we must do that, but often I think it's the case that even if you can perform an intervention, it's not necessarily in the best interest of the child. And therefore, because we have the experience of seeing what the outcomes are of children with similar injuries, we may be able to help facilitate those discussions about what we're doing, if it's the right thing for the child, and also facilitate those discussions with families as well. So I do feel that neurorehabilitation specialists should be actually brought in early in the child's journey. As soon as the time's appropriate, I think it's important that we introduce ourselves to the family and perhaps the child, because ultimately the neurorehabilitation team is many health professionals, and we will be having a very long-term relationship with these child and the families. So in the long run, they'll be seeing more and more of us as opposed to the treating or the admitting teams. What this diagram represents is the number of people around the team. So obviously at the center is the patient and the caregiver, but there are many other health professionals, particularly therapists, who do the important work with these children. And then there's a neurologist. The treating teams are always still involved. So for instance, with the neurosurgical patients, I would expect my neurosurgical colleagues to be part and parcel of the management team, and at Birmingham Children's Hospital, I'm very lucky that they are. And it's the other thing that I'm lucky in having is a neurorehabilitation coordinator, and her role is actually to ensure that we are not missing anything, that we're communicating well with each other, and in particular that we're communicating well with the child and the family. The other thing that we're very fortunate to have is from the Brain Injury Trust, we have a brain injury support worker. She's funded by the charity, but she has an invaluable role in actually supporting the child and the family, not just in hospital, but also when they finally get discharged. And she can communicate with the schools, etc., which is also another important role that she has. Now, it's important to understand the child. It is essential to actually get a good idea of where the child was prior to the injury. So it's essential to liaise with the parents and the carers, and where possible the school, to get as much information as possible. It may be that this child already had some pre-existing behavioral issues, may also have had some developmental problems. It's important to know what this child likes and dislikes and what their personality is, because then we can use those aspects of the child's interest in actually motivating them with the therapy input. And also it'll help us to set appropriate goals to motivate them as well. Now, it's important to have regular assessments of these children. And the types of things that we'll be considering when we assess these children are, for instance, the level of consciousness. Do they have any irritability? Are they confused? What we do know is that when you're emerging after a traumatic brain injury, irritability, agitation is very common. It's also important to know what the child's responses are to sensory stimuli. So for instance, visual stimuli, auditory stimuli, smells, touch, they can sometimes cause lots of irritation. And when children are in hospital, whether that be in intensive care on the ward, it's often a very noisy and busy atmosphere, and it's not necessarily conducive to the child's recovery. This is a nice diagrammatic representation of the various factors that can be involved in a child's behavior post-traumatic brain injury. So, as already noted, it's important to recognize pre-injury factors and the impact that may then have on the traumatic brain injury and the effects of that. Cognitive disturbance after the brain injury. There may be emotional disturbance, behavioral disturbance, and physical disturbance. But that may also manifest, for instance, with loss of executive functions. You may get anxiety and agitation and disinhibition, but there also may be headaches, there may be seizures. So it's important to try and look at behavioral management holistically. Now, with regards to the pharmacological interventions, what I tend to use a lot of in the first instance, if there's an acute agitation, is maybe a benzodiazepine, a small dose of diazepam. I rarely use chloral hydrate. Now, studies have shown that these are sedative and may actually reduce the cognitive and functional recovery. So they're not drugs that you should be using in the medium to long term. Other medications that you can potentially use for longer are propranolol if there's no history of asthma or bronchoconstriction. Methylphenidate, I think, is extremely helpful to use. And the other one that I've used sometimes is sodium valproate as a mood stabilizer. Now, the issue with methylphenidate is that it must be given in the morning. You can potentially have a second dose in the early to late afternoon, but you should not give a dose anytime sort of in the evening or just before bed, because that's then going to impact on sleep. These are stimulants, so you basically want to give them early in the day and not late in the day. It's also important to ensure that you manage the child's comfort. Pain is a significant issue that can cause agitation. And it's also important that you manage tone. And there are a number of treatment options available for tone management. And obviously, of these, the two most important ones are, I believe, to be rehabilitation, so physiotherapy and exercises, and also oral medications. The others tend to be more invasive, and I prefer not to use them unless necessary. Now, of the medications that I use, baclofen is the most common. The other one that's often worthwhile trying again is diazepam. Diazepam works very quickly in managing spasticity. Rarely do I use alpha-2 adrenergic agonists such as tizanidine and clonidine. They have a risk of potential hepatotoxicity, specifically tizanidine. Dantrolene is one that I do not use because that can actually cause hepatotoxicity as well. One that I do use quite often is gabapentin or pregabalin. These also help to reduce spasticity, but also help in managing pain. And the other advantage that pregabalin has over gabapentin is that it has an anxiolytic effect. So if anxiety is an issue, then pregabalin may be more helpful than gabapentin. It's also important to think about how you're going to move and handle this child or young person. You need to have optimization of the posture and positioning to make sure that they can interact well with the environment and activities. Also, you don't want them lying down for prolonged lengths of time. You've got to keep them moving because that helps to improve respiratory health or maintain respiratory health. And also interventions then to try and improve functions are important. And that's primarily going to be physiotherapy, occupational therapy, but also speech and language therapy. And then having the right equipment such as orthoses, standing frames, spinal bracelets, etc. are important. When you're assessing a child, it's also extremely important to assess how much they are aware of safety. If they are impulsive post-head injury, you need to make sure that you're aware of that so they don't actually injure themselves anymore because they're not being supervised enough. Also, it's important to allow the child and the young person to be able to communicate if they can, and therefore the speech and language therapist, together with the occupational therapist, will be able to ascertain the level of understanding that these children may have, and then also enable them to communicate, possibly by using communication aids. And even if they have the ability to make simple choices, that can actually avoid a lot of frustration and also then improve the efficacy of the rehabilitation that we're providing. Nutrition and hydration are important. So speech and language therapy and early swallow assessment. This is actually for many children something that they enjoy. So therefore, if you are able to instigate some oral taste or oral feeding sooner rather than later safely, then it's something that's worth doing. You need to assess for gastroesophageal reflux. Gastroesophageal reflux is one of the causes potentially of developing aspiration pneumonia, so you want to keep that under control. Drooling is extremely important to recognize, because this can have a very negative negative effect on the child's feeling of well-being, and it's important to look at that. Bowel habit, constipation causes distress, discomfort. It may be a cause for causing dystonia, and therefore that needs to be kept in check. And also, if these children, for instance, have issues with urinary retention, have a catheter in situ, you want to basically keep on looking for potential urinary tract infections, which may cause unnecessary discomfort and complications. Rest and sleep is very important in neurorehabilitation. So you want to give these children ample opportunity to have some rest and sleep, because that helps to improve their cognition and aid learning. And what we do know is that sleep disorders are extremely common after brain injury, and studies have shown occurring in 30 to 70% of individuals. And of those, insomnia, fatigue, and sleepiness are the most frequent complaints. So management of sleep problems, primarily it's sleep hygiene. So these are things that you will have used with your younger children at home. You know, making sure that they have set bedtime routines, that they're not having anything that's got any stimulants such as Coca-Cola, etc., or before they go to bed. CBT, cognitive behavioral therapy, can be helpful, and that basically looks at other techniques such as relaxation, sleep restriction, and stimulus control alongside sleep hygiene. And then you may be using pharmacological treatments. And of the treatments that are available in children, I think the safest one to use is melatonin, and that can help to improve sleep-wake cycle. Normally, I will start melatonin and continue it for at least 2 to 3 months before trying to stop it, to see whether or not the child still needs it. What I'm hoping is that within 2 to 3 months' time, the sleep-wake cycle will have shown natural improvement. Psychology input is important. Clinical psychologists can help manage emotional, behavioral, and sleep issues. They also provide much needed support to parents and siblings. Often siblings get forgotten, they're left at home or with other members of the family, whilst the parents are in the hospital with the sibling who has sustained the injury. For the parents, it's often a roller coaster ride. There's fear about what may or may not happen. There's anxiety about what may or may not happen. There's a lot of emotional baggage. They may be actually feel guilty that they're not spending time with the other child. They may feel guilty because the child has had the child who's had the injury. They feel responsible for that. They often have issues with maintaining their jobs because they're spending prolonged times in hospital with their child, and that then has financial impacts. And neuropsychology assessments are important to actually assess the nature and extent of the cognitive difficulties that these children have, put in the right support, and then monitor the progress. So rehabilitation does not follow a set protocol. It's an individualized process, and it changes and evolves as the child's condition improves and changes. So it's an ongoing process. And when it comes to goal setting, it's important to be smart and also plan the interventions and review what's happening. It's good to try and have objective measures of what you're doing. And this is just one example, the disability rating scale. This should be done repeatedly along the patient's journey, and it gives you an idea about how much improvement they are having, but it also helps you then set the next goals for that child and young person. Another important aspect of neurorehabilitation, which again is sometimes forgotten and left later in the child's journey, is discharge planning. Now, my view on discharge planning is that this needs to start early on. That's because there may already be pre-existing social issues. You know, for the number of children that we have with traumatic brain injury presenting to us in the West Midlands region, I think the majority of them already have existing social issues. And it's important to understand those and recognize those. That's then going to impact about how you can get the child home or somewhere out of the hospital safely. There may be housing problems. The child may now be wheelchair dependent, and therefore a small terraced house with 2 rooms downstairs, 2 rooms upstairs is not appropriate for them. My view is that when you're starting discharge planning, it's best to work on the worst case scenario as opposed to the best. Then think about the adaptations that need to be put in place and the equipment that needs to be there. When you're also thinking about discharge, you have to have a good idea about what resources are available locally. There is a massive variation across the regions about what is available in the communities. So for instance, in some of our communities, there's very little, if any, children physiotherapy or children occupational therapy there. And if that's the case, you probably do not want to rush to discharge these children from hospital where they are getting therapy input, because we're all aware that there is an opportunistic time to actually get the rehabilitation in place. You also need to think about the benefits that the child and the family may be entitled to. They may need nursing care support or social care support when they get home, and that takes a long time to organize. Parents and carers may need to be trained in looking after the children, for instance, if they're nasogastric tube fed or gastrostomy tube fed, or insertion of catheters, if they've got tracheostomy in place, about making sure that they understand how to care for these. And it's also very important to think about education. And that needs to start soon. You need to be able to liaise with the child's school to see whether they're able to take the child now with the difficulties that he or she has. If not, then you have to think about where else it may be appropriate. In the UK, these children should have education and healthcare plans put in place, and they can take many months to organize. And therefore, the earlier you start, the better. So neurorehabilitation is an ongoing process. You have acute inpatient rehabilitation, then you have acute outpatient rehabilitation. You have an ongoing home therapy program, and that's supported in the community and school as well. Often these children do not like performing what they regard as being mandated exercises, physiotherapy, for instance. And therefore you need to think outside the box. How can you motivate these children to take part in their therapy? How are you going to make it enjoyable for them? And that's when things like aquatic therapy, hippotherapy, which is horse riding for the disabled, massage therapy, music, drama are all very important. And these can be utilized to make doing the exercises fun and encouraging the child to carry on doing them. I'm just going to touch very briefly on spinal cord injuries. So in 2017-18 in England, there were 45 children admitted to a spinal cord injury center in England. There's 8 of these centers in England, and they had traumatic or non-traumatic spinal cord injury. However, this figure of 45 is probably an underrepresentation because there are very limited beds available for children and young people with spinal cord injuries anyway. And a lot of these children will not actually be admitted to the spinal cord injury centers. And I know of a handful of patients in the past couple of years at Birmingham who we tried to get to these specialist centers, but for one reason or another, we could not. Other considerations for children with spinal cord injuries is obviously the chest, ensuring that they have a good bowel routine and management, the bladder function, avoiding urinary tract infections, which may then cause more significant complications of the urinary tract. Pressure management is very important. Making sure that they get adequate nutrition and hydration, and obviously providing deep vein thrombosis prophylaxis for periods of prolonged bed rest. Another important consideration is the autonomic dysreflexia. This is due to disruption of supraspinal control to the sympathetic preganglionic neurons. It tends to be seen in children and adults who have an injury at T6 level or above. And for the management of autonomic dysreflexia, all children with spinal cord injuries should actually have a management plan in place. And that's firstly is to be aware of the signs and symptoms, which include things like headache, flushing, and sweating. When they have such symptoms, you sit them upright, you lower the legs, you remove any restrictive clothing, particularly in the legs, but also think about removing spinal braces, if they have those in place. Every 2 to 5 minutes. Remove any noxious stimuli, so things that might be causing pain or discomfort, and that means like checking the bladder, check that the catheter is not kinked, check that they're not constipated if they are, try and clear that, see if they've got any breakdown of skin or pressure sores developing. And if the blood pressure is still not settling, then you need to consider giving treatments such as nifedipine. In adults, we sometimes give glyceryl nitrate, but it's not something that is recommended in children. And if the symptoms are still not settling, they need to be transferred by ambulance to the emergency department. This is basically something that needs to be dealt with as quickly as possible. So in conclusion, neurorehabilitation requires a multidisciplinary approach. It should start, in my opinion, very early in the patient's journey. The nature of rehabilitation is individual to each child, so no child is the same. It is an ongoing process that changes as the developmental and functional needs of the child change. So it's basically an evolving process. And importantly, careful discharge planning is essential. And in order to be able to do this safely, you need to have knowledge of the social and home circumstances, the community services available, particularly the therapies in the local community. Thank you very much.
Thank you, Professor Gupta, for this excellent talk. I think there are quite a lot of questions in the chat box, and I think we have time for 2 questions. The questions in the chat box, they actually mentioned 2 things. One is regarding, I think, what we call like alternative therapies, and you touched the subject once, like music therapy. Is there any evidence for like acupuncture or music therapy, or should we do research after it?
So there's no good evidence or randomized control evidence for a lot of these therapies. However, my view is that I have got individual patients who have basically shown benefit with certain therapies. So I don't tell my parents not to try these therapies. I normally say that if you want to try them and let me know whether they've been helpful. What I do say, however, is not to stop any treatments that I may have instigated myself whilst they take on these things. So acupuncture, I think, is something that is worth trying. And some people use Reiki and all sorts of things. And again, I can't basically recommend them, but I don't actually put patients or parents off trying them.
Thank you. The other questions are regarding gastrointestinal problems. Like, when would you refer a patient to a gastroenterologist to place like a percutaneous endoscopic gastrostomy, or when would you refer to an endoscopist to rule out GE reflux?
So I think gastroesophageal reflux, you always have to have in the back of your mind. So if you've got a child who's basically having obvious vomiting, then that gastroesophageal reflux is something that you need to consider. If you've got a child who's having recurrent chest infections, I think it's worthwhile considering. And if that's the case, then a discussion with your local gastroenterologist, and or if you're confident enough, starting on anti-reflux medication sooner rather than later.
Rather than causing damage to the brain. Whereas the other retractors are costly, they require larger opening.
Sorry, I didn't quite get that.
I didn't hear.
I mean, with regards to the gastrostomy, once the speech and language therapist has assessed the child, and once we've got a good handle on the child and what we think the likely outcome is, if our feeling is that they're not going to be able to not able to get good amount of their nutrition by mouth, then we would be referring for a gastrostomy. Now, unfortunately, at Birmingham Children's Hospital, we have a very long waiting list. So even if I was to refer a child today, they probably would not get a gastrostomy for at least 4 to 6 months. And unfortunately, they'd have to then rely on a nasogastric tube. But our preference is for a gastrostomy insertion in those children who will not be able to take food safely orally.
Okay, thank you for this excellent talk. And I think we're back to you, Nina.
Thank you.
Okay, thank you very much. So I present our next speaker, Dr. Dieter Klaus, who is a consultant in pediatric neurosurgery from Magdeburg, Germany, and he does also voluntary work in Cameroon. So, Dieter, it's your time to speak.
So thank you very much.
Dieter, do you want to share your screen, please? Okay, thanks. Fantastic.
Sorry. Aaron, can you hear me?
Yes, yes.
Sorry, I made a mess here because I probably put the wrong button. It's something I wanted to avoid really, but sorry for this.
Working fine. It's working fine, Dieter.
But we are working on this. Is it okay? Can you see everything?
Yeah, we can see it. Yeah.
So I go to the full screen probably here.
You want to advance it because we can see the.
Okay, we can. I think we can leave it like it is now. So, first of all, Naren, I want to thank you very much for the invitation and for the idea to bring us together and to make all this possible, what we experience here. It's an honor to join this round. And I also want to say thank you to my colleagues, which are sitting on the right side beside me, who are helping me with some technical problems. Naren, you have always been a pioneer in transmission of information in neurosurgery, so this is the first time I take part in this kind of seminar, so I appreciate very much to be here. The topic of our talk was the topic of dystrophism, and I want just to start with some basic comments. As we all know, we are talking about a pathology with a wide variety, from a simple lack of fusion of the vertebral arches, as you see here on the plain X-ray done with a gentleman just for low back pain, to a severe deficit of neural tube closure with this young child who died only a few hours after the girl was born due to severe brain malfunction with apnea. So is everything okay with the presentation now?
Yes, it's fine, yes.
Thank you. So it's always a fact that at least in the Western world, in Germany and probably in other countries, this is a situation we see very rarely, meanwhile, due to the well-known reasons related to folic acid prevention concepts and, of course, the high numbers of children where we experience termination of pregnancy. So it's quite difficult also, especially for younger colleagues, to get to gain surgical experience in dealing with lesions like we see in this newborn child. And I think it's a great opportunity in this round to share, to comment on the experience we collected over the years. So whenever you see a child with a neural tube defect, which is introduced from the pediatrician just after it was born, there are basically two important questions the neurosurgeon has to answer. Is it an open lesion? That means nervous tissue is not well covered and subject to damage, as well as local or general infections. So this means that surgery will be needed within a short time frame. The other option is to see a closed lesion where nervous tissue is protected by skin, which may show just a dimple, a hair, birthmarks, or lipoma. Surgery may become necessary at a certain time but you have time to plan this very carefully. Spinal malformations may basically involve two of the three tissue layers important during the embryonic development, as we all know. Involved are the mesoderm and the ectodermal layer. In case the neural ectoderm is involved, primarily we see a child with an open spinal dystrophic lesion clinically presenting like a myelocele, meningomyelocele, or myelomeningocele. See that picture on the right. Is the tissue involved mainly the mesoderm? We expect a closed spinal dystrophic lesion, like a situation as you see on the right, the child born with a huge lipoma in the lumbar area. We may see children with diastematomyenia or pathological changes in the filum terminale. Especially the dermal sinus, I will go a little bit deeper into this entity, is related to a big risk of infections. The other problems like lipomas, like diastematomyelia, and problems of the filum terminale may be associated with tethering symptoms, or in case of the lipomas especially, we can experience a growing mass lesion or the development of epidermoid or dermoid cysts. The dermal sinus tract, in a way, is the bridge between the both tissue layers involved. That means the neural ectoderm and the mesoderm. We speak of remnants of incomplete neural tube closure, resulting from a failure of surface ectoderm and dermal elements to separate from the neural ectoderm. The tract extends from the skin surface, as you see here in this schematic drawing, down to the spinal fascia, the dura, and eventually ends up in the spinal cord. The risks, I already spoke about meningitis and myelitis, are also including CSF leakage, tether cord syndromes, or later on the formation of intradural dermoid or epidermoid cysts. Every now and then we see children with a dermal sinus tract, and going back to the history of the child, we ask what happened after birth. This girl was presented to our department at the age of 10 years. The mother reported that only once after birth there was a small amount of fluid exiting, eventually these small lesions, but this small lesion, nothing happened, and at the age of 10 years, the child was introduced actually by the orthopedic surgeon due to the fact that she had back pain. We made an MRI scanning and saw this small tract, and when we opened the lesion, we saw the correspondent situation with a tract extending over the dura up to the cord. The child developed very well, but actually she was very lucky that she had no problems with meningitis or other complications mentioned already when she was younger after birth. So if you see a child introduced to you after delivery in the Department of Pediatrics and you see a lesion like this, you wonder, oh, how ever can this be closed? So it's always important just to look at the lesion very carefully to see what are the different layers which may play a role finally. You see the normal skin, you see the transition zone, what we call zona dermatica, and you see here the really clearly to be seen neural tissue on the surface, and there's the zona epitheliosa rosa around. So these are the layers you have to deal with. You have to try to find an optimal solution to close the lesion, to protect the nervous tissue, and to prevent secondary tethering problems. And we all are aware that these are complicated surgical procedures, and it's normally very wise to prepare this carefully. These are very rarely when procedures done right in the middle of the night. It's better to prepare this for the next day, to have a good team around and to be prepared for possibly long-lasting procedures. So let's go through the different steps we have to have to consider, and we have to think of when planning to close such a lesion. We start with an incision in this layer where you think, oh, this is no stable material for closing, but actually it may give you more tissue for the closing procedure than you would expect at first having a look at this. Then you complete the incision around the neural tissue. Finally, you will find the dura, and it's wise to separate the dura from the fascial layer as far aside as you can, just to gain enough material for easier closure of the dura. But there's some technical detail you have to keep in mind, that the nerve roots in the extradural course on the ventral surface of the lesion must be protected, and it has to be considered that when separating the dura from the fascial layer, they are nearby, and it's very important to go step by step under, if available, optimal magnification and with an optimal light available. So finally, the dura is mobilized from the fascial layer, and we are ready to close the dura. It's very important to try to avoid as much tension on the nervous tissue as you can, just to avoid secondary damage. And of course, this may take some time, but it's really worth it, because we want to preserve neurological function to a maximum extent. And finally, you can close the fascial layer over the dura in addition, but it's always important to think that there must be some tissue, there may be some tissue needed when you think of closing a tethering lesion, when you have to go again into this pathology when you face a child developing a tethered cord syndrome. So it's very well if you have some tissue left for secondary closing procedures. This is the final step, and sometimes it's difficult to close the skin, and eventually, and every now and then, we ask for the support of our plastic surgeons. So to summarize the main steps and to come to a take-home message, it's important to think that surgical repair of all neural tube defects is challenging, as preservation of cord and nerve function is the most important goal to achieve. Careful wound closure is mandatory to prevent secondary CSF leakage when the patient may be discharged soon, for example, just because the family has no longer money available. So we already spoke about the problem of cord tethering. We see two forms, primary and secondary forms of cord tethering are known. Primary tethering may be related to lipoma, to thickened filum terminale, to diastematomyelia, to dermal sinus tract, or to the original defect of the neural tube closure. Secondary forms of cord tethering may be noted after a history of spine trauma, of spine surgery, or after a history of infection. What will we find? What would we expect? It's always wise to reflect again the embryological development of the spine and the spinal cord. When we bring these children to MRI scanning, we see this horizontal course of the exiting nerve roots, a finding which is always suspicious of a tethering lesion of the tethered cord symptom. We look where's the conus lying, is it below the level of L2? And of course, we look carefully at the thickness of the filum terminale. What are the clinical symptoms we see in these children? Strain-related back and pain in the back, rarely irradiating into the legs, weakness in the legs, new or progressive, including spasticity, sensory deficits, progressive disturbance of bladder functions, scoliosis, and deformity of the feet. Important for all these children, when you discuss the question, is the surgical procedure really necessary, is the question of secondary worsening or loss of function. Is a secondary worsening to be seen of a pre-existing deficit? And the key question is, will a tethered cord, seen often in MRI, which may lead to a tethered cord syndrome, ultimately require surgical treatment? We already spoke about the diastematomyelia. This is a special type of a split cord malformation, meaning the splitting of the cord in the sagittal plane into not necessarily equal hemichords. Mostly both parts, we form a single cord below the site of the division. Skin normally is intact, and in MRI scans we sometimes see other possible pathologies like vertebral anomalies, hydromyelia, or a low-lying conus. And eventually we see most of these patients, especially also in the adult patient group, the MRI you see on the right is done from an adult patient, symptoms of cord tethering. And this is the big difference to the diplomyelia, where you see similar findings in MRI, but rarely ever symptoms of cord tethering. When surgical aspects are discussed, when you come to the decision that will start with surgery, but you have to recommend this for the family, or you have to recommend this for adult patients. Your goal should be the complete resection of the diastema and the associated soft tissue around the lesion, the excision and reconstruction of the ventral dura, the reconstruction and careful closure of the dorsal dura, and the multi-layer closure of the dura and all the soft tissue above the lesion to prevent CSF fistula. The gentleman whose MRI I presented on the first slide dealing with this problem was operated, but we had really to fight with the current CSF leakage. So these are surgical challenges where you have really to consider very carefully in advance, is the surgical procedure really necessary? Some comment on spinal lipomas, just to round the talk a little bit up. What happens here, the disjunction or the separation of the neural tube from the surrounding ectoderm occurs prematurely, leaving the neural plate open posteriorly and allowing mesenchymal cells to enter this cleft. This is a schematic drawing which shows what's going on. The clinical picture is impressive, and that's what we see in the MRI when we take these children for imaging. Professor Pang described in his well-known classification 3 main types: the dorsal type, the transitional type, and the terminal lipoma. I just want to mention this because I know that there's a comment presented tomorrow, I think, and we all know that the neurosurgical treatment of children's spinal lipomas is also really challenging, and our goal is the microsurgical excision of the lipoma as far as possible, separating the interdural and extradural components of the lipoma. We normally do this only by recording of AVO potentials during the whole procedure. And the indication for treatment is the growth of the lymphoma or the existence of symptomatic cord tethering. To come to a conclusion, I want to give a short comment on fetal surgery. There's intensive debate on this situation, and the MOMS trial showed advantages for a group of pregnant women and children, but up to now, only few centers are trained and equipped well enough to gain experience of routine needed in the procedure. In Germany, we have just one neurosurgical group with experience, including a bigger number of children. So for most of the children with thoracic lesions around the world, standard microsurgical treatment after delivery may probably be the primary option still. So again, thank you for your kind attention. Thank you for your patience. We had some problems starting. Thank you for Naren again for making this possible. Greetings from our team here, from my colleagues, and all the best for your health, for your work, for the sake of sick children all over the world. Thank you very much.
Thank you very much, Dieter. I think there is a lot of questions in the chat, so let's probably continue without answering questions online to the next lecture. And if you can kindly answer the questions in the chat, there is really many questions because we're a bit out of time.
Thank you.
Keep up with. Thank you very much.
The next presenter is Professor Suwon Tu from the National Neuroscience Institute in Singapore, and he's a Melbourne and London-trained neurosurgeon with a special interest in brain tumors. And his talk is about pineal tumors. Professor Su, the floor is yours.
Right, thank you very much. Hi, everybody, and welcome to this conference. Well, I'm not welcoming, but hello to everybody from Singapore. Okay, so Naren has asked me to talk on pineal tumors, so I'll just get going. Okay, all right. So what's the pineal gland? I think most of us know where it is, right? We see it in our MRIs all the time. Here's a small little cyst in the pineal region. So basically, it's a lobular structure. There's some pineal cytes. These are cells from the pineal gland itself, some astrocytes, connective tissues, blood vessels. And these pineal cytes are actually specialized neuroepithelial cells. They secrete melatonin, serotonin, and pineal peptides. And basically, these are supposed to be modulating the circadian rhythms in the body in response to the cyclic variations. Now, when it comes to pineal tumors, actually, the pineal tumors generally are not so common. There are multiple histological sites, and there are also racial and geographic epidemiological differences. And actually, they are generally very rare, about less than about 0.5 to 1% of all brain tumors that we tend to see. Now, the diverse histological types, I think there are tumors that arise from the germ cells of germ cell origin, tumors from the pineal cells, the pineal cytes that I mentioned earlier, tumors of adjacent structures or supporting tissues, and neoplastic masses that are around the area. So actually, you can divide them into germ cell tumors, pineal parenchymal tumors, gliomas, meningiomas, ependymomas, metastases, and so forth. And basically, we're going to talk a lot about these things. Now, first, we talk about germ cell tumors. They are supposed to arise from the primitive germ cells, which fail to migrate normally in early fetal development. And interestingly, in our part of the world, so in the Far East Asia, we actually have a high incidence of this. We see a lot more of these tumors than people from other countries. And the most common type of germ cell tumor is the germinoma. So we have the germinoma, and there are also various other names. Like, for instance, you see also the seminomas in the testis, and then also even in the ovaries. Then you have what we call the non-germinomatous germ cell tumors or secretory germ cell tumors. These are the embryonal cell carcinoma, yolk sac tumor, choriocarcinoma, and then the teratomas are various different types. The malignant ones, the mature, so these are actually benign, and then the immature, which are also benign. And you have something called a mixed germ cell tumor, which I'll talk about. And then some people will consider the dermoid also as a germ cell tumor. So you can see that in the germ cell tumor, there are actually two groups, right? Especially group coming off becoming the germinoma, and then the tumors of totipotential cell, all right, then which then becomes the embryonal carcinoma, which can also differentiate into yolk cell, choriocarcinoma, or the teratoma. Okay, so this is the origin of this type of tumors. The usual location of germ cell tumors, always a large part of them are in the pineal region, but there are also a group of them coming up in the suprasellar region, right? And then you can also see germ cell tumors in the basal ganglia, in the ventricles, in the spine. Now, interestingly, a lot of the germ cell tumors, when they occur in the pineal region, they occur in males. In the suprasellar region, they tend to be females, but of course, this is not always true. I think a very important aspect of germ cell tumors is the presence of tumor markers in the blood and also in the CSF. And you can get them, the CSF, you can actually do LP if there's no hydrocephalus, lumbar punctures, or do when you're doing a ventriculostomy to treat the hydrocephalus, you can get CSF. Right. So basically, if they express the embryonic markers, the basically beta HCG and alpha fetoprotein, they are the non-germinomatous germ cell tumors or secretory germ cell tumors. Pure germinomas always only secretes this PLAP, placenta, alkaline phosphatase, and also placenta, the human lactogen, which not everywhere, in every place you can get these tests done. But actually, it's very important to know about these tumor markers, because if you can analyze the serum and CSF for the presence of these markers, that will help us in further management, right? Generally, they are quite diagnostic of the type of tumors, but so if you have a high tumor marker level in the blood or in the CSF, and you have a pineal or suprasellar tumor on imaging, most very, very, very likely you are going to be seeing a germ cell tumor. All right, so what sort of tumors secrete what sort of markers? So the embryonal cell carcinoma, which is the more potential cell, it secretes both alpha fetoprotein and beta HCG. The endodermal sinus tumor, or the yolk sac tumor, mainly alpha fetoprotein. The choriocarcinoma, mainly beta HCG. And the teratoma, the mature teratoma, benign teratoma, do not secrete any markers, but immature malignant ones will. So this also, you can actually then detect the numbers. Now, in this diagram, you can see that actually germinomas with what it calls syncytial trophoblastic cells will also secrete some amount of beta HCG, but the level of beta HCG in this group of tumor is actually quite low, right? Usually less than 50 international units per liter. So if you have a very low beta HCG, a pineal tumor, it probably is a germinoma. Whereas if you have a choriocarcinoma, the beta HCG level is actually very, very high, all right? So these are some of the tests that you can see and the numbers that you will see when you start doing this tumor marker tests. I mentioned about a growing germ cell tumor. So basically what this is a mixed germ cell tumor, meaning there's either a germinoma or a non-germinated germ cell tumor with a benign teratoma existing in the same tumor. And what actually happens is that after you have started chemotherapy, radiotherapy, the malignant component dies, but the teratoma, being benign, not affected by your treatment, continues to grow in size. So usually you would talk about growing germ cell tumor after you have started therapy for this tumor. So for instance, we have a 5-year-old patient with a pineal region tumor, right? The beta serum HCG was slightly raised, so this patient was presumed to have a germinoma. He was started on chemotherapy, and then after the treatment, you find that this tumor continues to grow. Now, in this case, what you're seeing is actually more like a cystic area, but with solid components. And this is classically what looks like a teratoma on MRI. So this is a growing germ cell tumor. Then the next type of tumors we see are tumors of the pineal parenchymal cells. They are the pineocytoma, which is benign. The pineal parenchymal tumors of intermediate differentiation, or PPTID, and the very malignant tumor, the pineoblastoma. And in the past, when we were using terms like PNET, which we don't use anymore, this would be called a pineal PNET. Then, of course, you get other tumors like gliomas, and classically, you see tectoplate gliomas, all right? But then you can also get grade 4 type of tumors or low-grade gliomas. You can also get meningiomas, and you can also get lipomas as well. So what are the signs and symptoms that you see? So I think the most common sign and symptom that you see would be raised intracranial pressure from hydrocephalus, but also you can get tumor, large tumor masses causing raised intracranial pressure. So obviously we know what the type of symptoms that you get from raised intracranial pressure, especially from hydrocephalus: headache, nausea, vomiting, they are papilledema, bilateral six-nerve palsy, and specifically for tumor region tumors, you get Pineal syndrome, which I will discuss in a short while time. If the tumor actually goes posteriorly into the cerebellum, you can even get cerebellar symptoms. Now, many times, although we can see only a tumor in the pineal region, there are also metastatic lesions in the suprasellar region, giving rise to endocrine disturbances like diabetes insipidus, precocous puberty. All right, so basically, the suprasellar involvement, you will get the endocrine disturbances. Pineal syndrome is caused by pressure distortion underlying pathways in the brainstem, not specifically by damage to specific pathways in the colliculi, but it's a combination of impaired upward gaze, impaired down gaze, so they cannot look up, they can look down. So classically, the sun-setting eye that we see in hydrocephalus is also part of Pineal syndrome, right? They get pupillary anomalies, loss of accommodation reflex, and refractory nystagmus. Now, imaging is obviously important. You will see a tumor in the pineal area. Now, when you do imaging and you see two lesions, so like a tandem or bifocal lesion, both in the pineal, in the suprasellar region, you're always looking at a germ cell tumor. So there are people who feel that this could be the primary, this could be the secondary, but it could be the other way as well, right? So, but basically, they're all germ cell tumors. So what are the aims in management? I talk a lot more about germ cell tumors because basically they're the most common type of tumors in our part of the world. Every year we'll see about 2 or 3 of these tumors, much more than actually the number of pineal tumors you might see in other parts of the world. So the main thing is to relieve hydrocephalus. Then of course, we still need a biopsy, right? Because you need to know the histology before you can commence any treatment. And then of course, if the tumor is a benign or it is chemo-resistant, so it's a growing germ cell tumor, then you need to consider craniotomy. And of course, another part that we need to do is to get markers. So if you can test it, if you can find the blood, that's fine. But if it's not available in blood, you may actually want to do a lumbar puncture or during part of your ventriculostomy to actually take CSF. So the treatment options for pineal tumors, you need some form of shunting procedure for hydrocephalus. Then you need to consider surgery, whether it's just to do a biopsy, you do a surgical excision, and what we call second look surgery, which I'll talk about. Then of course, for the malignant tumors like germ cell tumors and the pineoblastomas, they'll need chemotherapy and radiotherapy. Right? The good thing about pineal germ cell tumors is that they're all chemo and radiosensitive, but not so much so for the pineoblastomas, which you tend to treat like what you do for medulloblastomas. So how do you manage the hydrocephalus? Basically, in pineal region, the hydrocephalus is caused by blockage of the aqueduct. And so in this sort of situation, the ETV is actually very useful. And usually when we do ETV, we also attempt to do a biopsy. So basically, we will do a ETV first, and then we'll go backwards, look backwards, and do a biopsy. Now, there are people who say maybe you should do the biopsy first and then do the third ventriculostomy so that you don't have a lot of blood. But for me, I would always do the third ventriculostomy first because my main aim is to treat the hydrocephalus. If I can get biopsy, there are other ways of getting the biopsy, but I need to treat the hydrocephalus first. Okay. So how do you treat that? Do the ETV in pineal tumors? So the standard burr hole, right? So just in front of the crown sutures and about 2 to 3 centimeters from the midline. And then you just put your scope in, right? And then you go backwards, turn the scope and do a biopsy. So look at this case, a 1-year boy with person vomiting, unsteady gait. You can see massive hydrocephalus tumor in the pineal region. In this patient, the serum markers were negative, right? So here we can see as we go in, and they are now going into the foramen Monroe, and you can see the tumor inferiorly, all right? Quite a vascular-looking tumor. And then, of course, here are the 2 mammillary bodies, and you can see the floor. Now, interestingly, if you look at all these white dots, these are actually metastatic lesions, all right? But here we are just doing the ventriculostomy. So I usually make a perforation with a blunt object, and then pass in a Fogarty balloon. Okay, we might just see where we can do a little bit faster, go a bit faster. Okay, so put the Fogarty balloon, right? And you can see we're through, right, into the aqueous membrane. You can see the vessels clearly. So the treatment is, the third ventriculostomy is done. Then you go backwards. Now here I was trying to just monopolize, coagulate the tumor, right? But usually you'll find that it's not possible to really coagulate it. And these tumors will bleed, but usually the bleeding is not that difficult to control. And with a bit of a wash, you will actually be able to stop the bleeding. And this turned out to be a pineoblastoma. Okay, but it's not possible to actually see the tumor in all cases. So for instance, right, so, and if you try very hard to try to get the tumor, you can actually damage the, usually you damage the fornix at the, where you're going in through the foramen of Monroe. So it's not a good thing. So like for instance, in this case, if you, we did a third ventriculostomy, right, went well, but we were not able to see the third, the tumor. So what do you do? So if you have a flexible endoscope, you can use a flexible endoscope that will help you get a biopsy. But if you can't, you can actually consider putting a separate burr hole in the frontal region, just around the hairline, and then use image guided to get you into the foramen Monroe, and you can see the tumor. So in this case, this is what was done. You can see here, all right, this is the attempt going through. Can you see into the foramen Monroe? And then, so here we are, and you can see the tumors at the back here, all right? So here you go, you can see the tumor, and you can very easily biopsy it to this procedure, to this approach, okay? You see that you can actually damage a bit of the anterior part of the foramen Monroe, so you got to be very careful in this situation, okay? And this turned out to be a germinoma. So you can also sometimes see metastatic lesions on the floor of the third ventricle. So in this case, a third ventriculostomy was done, and you can see this is the floor of the third ventricle. This one of the, these are the memory bodies here, and you can see there's a lesion here which we took out. And again, it also showed a germinoma. We were able to, in this case, to look backwards and grab a biopsy of this tumor, as you can see. Now, when do you do open surgery for pineal tumors? Right? Obviously, when you're unable to get biopsy, when the biopsy shows that the tumor is not a germ cell tumor, because germ cell tumors, like I say, are very radiosensitive, very chemosensitive, and they respond very well to this adjuvant treatment. But if it's not a germ cell tumor, or if it is a germ cell tumor but a benign teratoma, then obviously you need to do open surgery to remove the teratoma. All right. There are also some neurosurgeons, actually my colleagues in Japan and in Korea, who sometimes see what they think would be a teratoma, and usually you have that bubbly appearance as we mentioned earlier, and they may actually go straight ahead and do open surgery. And then we do what we call second look surgery. Second look surgery means that just in case there's still remnant tumor after chemotherapy, radiotherapy, you will want to consider doing that. So what are the surgical approaches? So you can do an infratentorial supracerebellar approach, the occipital transtentorial approach. Some people also do a posterior interhemispheric approach. And then in the past, people used to do stereotactic biopsy, but that's usually not recommended because there are many veins and the bleeding rate is much higher than in other types of stereotactic biopsy. So the supracellular infratentorial approach, I think you all are very aware. You actually do a posterior fossa craniotomy, go above the cerebellum into the pineal area, right? And you can, and so this is the anatomy they see. Basically, you have the vein of Galen coming up, joining into the straight sinus, and then the two basal vein of Rosenthal, and the tumor is usually in this area. Most people would consider doing it in a sitting position, but there are some of us, like I, tend to do it in a concave position, right? So this is the patient prone, but the head raised and tilted to the side. And basically, you do a posterior fossa craniotomy, and then you go supracerebellar, right? And you can see as you go, and some of you may have to take out some of the veins, especially the central cerebellar vein, and then the cerebellum collapses downwards, and you are there into the space. They see a very thick area of arachnoid tissue around there. You slowly dissect that, and you will be able to see tumor here, right? And then you can, once you have removed the tumor, right, and you're below the veins, so it's actually fairly safe. And you can even see the corpus plexus in the third ventricle in the thalamic adhesion. Right. Now, people also are starting to use the endoscope, what they call endoscopic suprasellar approach. They use the endoscope the way that you would use the endoscope to do a transsphenoidal surgery. Basically, you use it to actually see so that you have a bit less restriction. And basically, it also gives you a much better view of the area, although it's 2D, not 3D. All right, so you can see this comparison. And there are actually several reports in the news, in the journals, okay, indicating how people approach these lesions. Right, so using, and I can foresee that in the longer term, there'll be more and more people using this methodology. Another very common approach is the occipital transtentorial approach. In this case, what you do is you do a occipital craniotomy on one side, close to the midline. You lift up the temporal lobe, the occipital lobe. Then you actually cut into the tentorium to expose the pineal region. And most patients will be in some form of a park bench or even just a prone position, a head turned to one side. Right, so you can see here the occipital lobe on the inferior part is actually lifted up to expose the tentorium. All right, and then you cut into the tentorium, and once you cut into the tentorium, you are actually within the pineal region. Okay, so this is another photograph which shows you this is the retractor retracting up the temporal lobe. Right, once you've done that, you can see the tentorium, you cut into it, and you are actually able to expose the area. Right, so temporal lobe, occipital lobe retracted, cut into the tentorium, and you can see tumor is really right in front of you. Okay, and then you remove the tumor, as you can see here. Right, so this is another one in a pediatric patient that Professor Piaget showed me a case like this. Right, so a recurrent tumor in the pineal region. In this case, the patient was just in a prone head turned to the left, and you can see the occipital craniotomy, lifting up the temporal lobe, making a cut using the monopolar into the tentorium, and you can see the tumor is there straight away. And of course, once you remove the tumor, you can even use the endoscope to actually have a look and try to remove more than what you can see just with the operating microscope. So there are some people who do also the interhemispheric approach posteriorly, right, going into the just above the inferior part of the corpus callosum, all right, and then using again gravity to retract down the hemisphere. So they always get asked the question, which is the best approach? Is the infratentorial suprasellar approach better, or is the suboccipital transtentorial approach better? To me, actually, I don't think the difference is that great. It all depends. I think most of us have been trained to do one approach or the other approach. And it will be quite silly of you if you have never say, you've always been taught and have done infratentorial suprasellar approach to actually then start doing a suboccipital approach, because some people say that, well, when the tumor is lower, the suboccipital transtentorial approach is better. I think if you are very good at one method, and remember, these tumors are very rare, and so not everybody has an opportunity to do both approaches at one time. And so I would tell you that if you are used to doing one particular approach, just stick to it, right? Your chance of actually causing less damage is much, much better, okay? Because basically there is a whole list of complications related to surgery for the pineal region. I mean, you get complications related to the sitting position, embolism, tetraparesis if you bend the neck too fast, but the risk of, and the transtentorial, occipital transtentorial approach, visual cortex injury is not uncommon, but many people end up with vascular injury. It's basically damage to the deep venous structures, right, causing patient to become comatose, and of course all the other complications that I've listed here. And so the mortality rate is not low, it's still close to 5%, and that's quite high. And morbidity rate actually is higher, right? And of course, if you just biopsy, the surgical risk is very low. So one of the things that we have done is that we also, because we deal with a lot of germ cell tumors, we actually have some sort of protocol. And this protocol is actually written up by Paul Steinbock in the Paediatric Neurosurgery more than almost 20 years ago. Basically, the thing is that you suspect a Pineal tumor on MRI. Obviously, you need to take the serum for tumor markers, and then also decide whether there's hydrocephalus or not. If there's no hydrocephalus, you will do a third ventriculostomy, and then you do a biopsy and you take CSF for markers. If there's no hydrocephalus, you may want to consider LP for CSF markers, especially if the serum markers are negative. So for instance, in this case, a 15-year-old, you can see on the CT scan, there's calcification in the pineal region, right? And he's got a pineal tumor for sure. Interestingly, he's also got diabetes insipidus, although there's nothing on the suprasellar region, and he's got a positive Paranol syndrome. Okay, so this is the MRI. And you can see, right, nothing very much here, but actually the beta HCG is low, alpha fetoprotein low. So we did a ETV, we measured the biopsy, it was a germinoma. The CSF beta HCG in this case was actually a little bit on the high side, but not very, very high. So again, germinoma with probably syncytial trophoblastic cells. Okay, so, and then you can see that's all that's done 3 months after chemotherapy and radiotherapy, tumor's gone. After 2 years, tumor's gone. And many of these tumors don't recur even up to 10 years of follow-up, although we have a couple of cases that had recurrence much later. If you have positive tumor markers, right, then actually, again, no need biopsy. You assume it's a malignant or germ cell tumor or non-germinative germ cell tumor. You start chemotherapy, radiotherapy, and then consider second look surgery if there's residual tumor. Okay, so for instance, this case 2, this is a 14-year-old boy, headaches, vomiting. You can see he's got a pineal region tumor. All right, now the beta's HCG was very high, right, 1800, right? And so even then you can notice we actually subsequently did a ETV, beta HCG was only 21, right? Actually, we tried to do an ETV, but we couldn't. So in the end, we actually had to shun him because of hydrocephalus, but we didn't consider biopsy, right? And then later on, the tumor was, you can see after 2 courses, just of chemotherapy alone, the tumor was actually starting to shrink. Right? And then this is a boy with a giddiness, polyuria, polydipsia, and you can see actually he's got a tumor surrounding his the whole ventricular system, right, lateral and third. And basically he had obviously diabetes insipidus. And in this case, his CSF, we did that through a lumbar puncture, right, because his alpha, the serum levels are negative markers, right? So he did this LP and it was high, and we treated him like a germ cell tumor, and you can see after chemotherapy, tumor disappeared. So he never actually had a shunt or ETV, and that was all that was done for him. Now, if you have the ability to test for placental alkaline phosphatase, PLAP, and not very many centers in the world have it. In Japan, they have it. I here understand some parts of Canada has it. We don't have it in Singapore. Many parts of the US, they don't have. Now, if you have this test and the serum is positive, you assume this is a germinoma, and you just treat as if, it's a germinoma. So chemotherapy, radiotherapy, no need even to biopsy at all. But if your tumor markers are negative, then this is where, it may not be a germ cell tumor. So you need to look at the CT, MRI, consider is this a germinoma, not a germinoma. If you're not sure, you want a biopsy and you treat as per histology. Or you can try chemotherapy or radiotherapy. And I remember in the past when you have a pineal region tumor, this is more than 20 years ago, even in our part of the world, they just get a week of radiation. If the tumor shrinks, it's probably a germinoma, and then they carry on. Okay, otherwise, so if there's good response, you assume you're treating a germinoma, you treat. If not, then you probably have to consider open biopsy, resection, and so forth. So this is where most of the surgeries for non-germ cell tumors are done. So like for instance, this is a 33-year-old female. This is a case that I took from my adult friends, history of migraine, headaches. The MRI done showed a pineal tumor. The markers were negative, right? You can see this is a tumor in the pineal region, okay? And obviously you can see that there's actually, this enhancement even of the tentorium and things like that. So anyway, they went in and it turned out to be a meningioma. Right? So I think in adults, you might see more of non-germ cell tumors than you see in children. So second look surgery, as I mentioned, is surgery performed for residual tumor following chemotherapy or radiotherapy, especially if tumor markers are still positive. What you usually encounter is that you usually have a smaller tumor mass. Tumors are usually less vascular, but sometimes actually it may also be a scar tissue or a mature teratoma. But usually a second look surgery is an essential part of the armamentarium that we have. And look at this case. This is a growing germ cell tumor. This child actually had a germinoma. On histology. We actually treated chemotherapy, radiotherapy, and actually the tumor disappeared. Then it came back, and then it started to grow. The parents didn't want to have further surgery until much, much later. And by the time the tumor had grown so big. And interestingly, we couldn't remove all the tumor. We observed the child. The tumor recurred, and this time it became a adenocarcinoma. So obviously the teratoma cells in the tumor became malignant, which was quite sad. He died from the carcinoma. So in summary then, pineal tumors are very uncommon. They're actually very diverse. In our part of the world, the germ cell tumors are commonly seen in this region. Right? If they are non-germinators germ cell tumors, they will secrete tumor markers. And the protocol management strategies are very useful. Surgery or biopsy for these secreting germ cell tumors can be initially avoided. And in those cases, radiotherapy and chemotherapy can be primary treatment in the presence of tumor markers. These tumors commonly present with hydrocephalus, hence treatment with third ventriculostomy and concurrent endoscopy biopsy is the key. Excision is necessary for teratomas and obviously non-germinators germ cell tumors. And second look surgery should be considered if they are residual after adjuvant therapy. Now, most of you know that the 48th annual meeting of the ISPN was supposed to be in October in Singapore. Now, this because of the COVID situation, and we know that Singapore will not be fully opened up for big meetings by October. This has been postponed to 2021. The good news is we probably will be hosting the ISPN meeting together with the World Congress of Neuroendoscopy meeting at the same time. So I look forward to seeing you all in Singapore next year, and stay safe in the meantime. Thank you.
Thank you, Professor Su, for this excellent talk on a pretty actually difficult topic. You were so complete that all my questions were answered. There are still 2 questions in the chat box. And one is about whether you should do the ETV or the biopsy first, which you already answered. You favored doing the ETV because you want to get rid of the hydrocephalus?
I mean, that would be my preference, but I know of other people who say otherwise. So
what is the reason for doing the biopsy first?
Well, the thing is, I think the main problem that we are dealing with the hydrocephalus, and I think you should be able to actually treat the hydrocephalus first. Some people argue that if you were to do a biopsy first, you might cause a lot of hemorrhage. The hemorrhage can block up the third ventriculostomy, and the hydrocephalus will come back again. But I think if you are going to do a biopsy, you will make sure that you stop the hemorrhage first. But of course, there's a possibility that sometimes you can get uncontrolled hemorrhage, and then you actually end up with a problem. Obviously, in those situations, you need to put an external ventricular drain after that. I mean, for germ cell tumors, especially, the risk of hemorrhage, is actually very low. I mean, I've done a lot of biopsies in these soft tumors, and I've not had major issues.
Okay, great. I think we'll leave it for that. Thank you very much.
Thank you.
Narayan, back to you.
Thank you very much. Thank you very much, Professor Tu. It was a fantastic talk. Thank you very much to Dr. Nina Salakopi and Dr. Dennis Buse, fantastic chairmanships. And so just housekeeping, we will reconvene in 30 minutes. We have got a fantastic session in the next session, starting off with thalamic tumors from Dr. El Batagi, and then finishing with Dr. Deepak Gupta from Delhi, as well as Professor Goel on craniocervical instability. So that's a great program, another great program we have. In terms of CPD, the requirements from the Royal College of Pediatrics and Child Health is that I need to get feedback from you for each talk. And so what I will do is I will, at the end of the day today, for the day one, I will, at the end of the last talk, I will send you the link that if you can please fill the feedback form, then that will allow us to give you certificates with CPD, continuing CMA, continuing medical education approval as well. So thank you very much, and have a break, and let's meet in half an hour's time. Thank you.
Thank you very much. See you.
Thank you. Thanks, Prof. Thanks, Dennis. Fantastic.
Thank you. Bye.
Thanks. Thank you.